My name is Mikayla Borusiewicz, and I'm a resident at Penn State Hershey Medical Center.
We have no financial disclosures. The current literature does not capture patterns of postoperative opioid use in pediatric patients undergoing plastic surgical procedures in a systematic fashion, namely in the case of cleft lip and palate repairs or subsequent revisional procedures. At Penn State Hershey Medical Center, our pediatric patients undergoing cleft surgeries and revisions are routinely discharged postoperatively with a short course of opioids as an adjunct to non-opioid analgesics to be administered at their parents' discretion. In general, patients undergoing cleft palate repairs typically stay one night in the hospital before discharge, whereas cleft lip repair and alveolar bone graft patients are typically discharged the same day as their surgery. In this study, we aim to gather data about patterns of postoperative opioid use in this population at our institution. Given the potential dangers associated with inappropriate opioid prescription, including respiratory depression and dispersion of unused narcotic, we sought to identify whether the prescriptions given to this patient population are appropriate. In doing so, we aim to tailor our prescribing patterns to achieve pain control with the shortest effective course and to grant the ability to offer more informed anticipatory guidance to families regarding their children's postoperative pain. We hypothesize that opioids are often overprescribed for these procedures. This prospective survey-based study was approved by the Institutional Review Board and included patients undergoing cleft lip and/or palate repair, revision cleft procedures, and alveolar bone grafting by one of 3 craniofacial surgeons at Penn State Hershey Medical Center. Families of patients consented at the time of surgery were contacted 7 days postoperatively and administered a standardized questionnaire by phone. Via this phone call, we administered a survey to determine patterns of postoperative pain control, including number of doses of opioids used, duration of opioid use, number of doses remaining, duration of ibuprofen and/or acetaminophen use, and satisfaction with postoperative pain control. Patients ranged between 4 months and 17 years of age, had a length of stay less than 24 hours, and were treated as outpatients. Patients who underwent cleft lip repairs were not prescribed opioid pain medication upon discharge and used over-the-counter medication for an average of 5 days postoperatively. Most patients who underwent cleft palate repairs received a prescription for oxycodone, 5 mg per 5 ml oral solution, with a total of 0 to 12 weight-based doses. Patients who underwent alveolar bone grafting received a prescription for oxycodone oral solution or oral tablets with a total of 10 to 12 weight-based doses. On average, 80% of the prescribed opioid medications were unused at the time that our phone survey was administered. Patients who did use opioids for postoperative pain control utilized them for an average of 1 to 2 days postoperatively. Additionally, 5 out of the 14 patients who were prescribed opioid pain medications did not use any of their prescribed doses. On a scale of 1 to 10, average satisfaction with postoperative pain control in all patients included in the study was 9.6, regardless of opioid prescribing and use. Ultimately, this study provides insight into postoperative pain control in a specific pediatric population. Patients with cleft lip and/or palate often undergo multiple stage procedures, and we aim to optimize postoperative care while minimizing unnecessary repeat opioid exposure and narcotic surplus. This study suggests that opioid use is often limited to 1 to 2 days postoperatively. Therefore, we continue to implement prescribing practices to limit opioid pain medication and to encourage over-the-counter alternatives.